Okay, so we are live in 3, 2, 1. Sir, please start. We are live.
ये भी करना है.
Hello, good evening, everyone. It's a pleasure to welcome you all for this meeting, and I think we have greetings from Bengaluru, pleasant weather, and we are going to talk on the recent updates in the management of lung cancer. It's a great pleasure to welcome. It's a pleasure to welcome Professor Dr. Poonam Patil, ma'am, a senior consultant medical oncologist from Manipal Hospitals, Bengaluru. Good evening to you, ma'am. We request you to set the ball rolling with your welcome and introduction. Over to you, ma'am, please.
Yeah, thank you very much, Mr. Mathur, and a very, very good evening to you all today. And it's really a pleasant weather here in Bangalore today. And today's meeting is on non-small cell lung cancer with focus on EGFR mutated lung cancer. So small molecule EGFR inhibition, such as with drugs like geftinib and erlotinib, have demonstrated clinical efficacy in the treatment of EGFR mutated lung cancers. But after earlier disappointing results, we really have come to the second generation, third generation, whenever the patients relapsed after these first generation EGFR inhibitors. And it was also understood that time that T790M mutation, which is a gatekeeper mutation, is for the possible responsible culprit for resistance to these drugs. And that is where a new drug was designed, that was osimertinib, which targeted the T790 mutated enzyme, but it did not do anything to the wild type. That is why this drug was so well tolerated. It did not have as much side effects as people thought. Then non-small cell lung cancer had its own characteristic of increasing percentage of brain metastasis as the survival increased. And osimertinib also had an edge over the other drugs because it did penetrate the CNS and it did have some effect on brain metastasis as well. So here comes osimertinib, which is a paradigm changing drug in the management of EGFR mutated lung cancer. It was earlier used in metastatic lung cancer only, which were exon 19 or exon 21 mutated. But then it has gradually and rapidly actually moved up the ladder, and it is also used as adjuvant in early lung cancers after surgery. So we have today an excellent session, and the first talk will be by Dr. Aditya Murli. He will be talking on optimal management of EGFR mutated non-small cell lung cancers. This will be followed by Dr. Neeti Raizada's talk on new paradigms in the treatment of early non-small cell lung cancer. And after that, a scintillating panel discussion by Dr. Rahul Sood. And he has got a very eminent panel of medical oncologists, and we are sure to have a good time today evening. So I welcome Dr. Aditya Murli for the first talk. Dr. Murli, he is a consultant medical and hemato-oncologist at Aster CMI Hospital in Hebbal, Bangalore. And we are very honored to have Dr. Aditya Murli despite his hectic schedule. And as he said that he is going to talk from the airport. Wow, Dr. Aditya. Welcome.
Thanks, Dr. Poonam, for such a kind introduction. I hope I'm audible. Am I audible?
Yes, yes, you are audible.
Yeah, thanks, ma'am. So, what I thought to speak over the next 30 odd minutes, you have wonderfully encapsulated in the 2-minute simple talk which you gave. So, I don't think there's much left for me to say. However, just trying to pick out some nitty-gritties over the next few minutes. I will be speaking about the optimal management of EGFR mutant non-small cell lung cancer. Next slide, please. Why are we talking about lung cancer today? Go to the next one, please. Yeah, so basically lung cancer has emerged as the most commonly diagnosed cancer among both the sexes, and it is the leading cause of cancer death. Nearly 20% of all cancer deaths are due to lung cancer, and this is the latest Global 2018 data. So what we want to examine are what are the first line treatment options that we have for patients with EGFR mutant lung cancer? And will using the the best medical, best TKI first make a difference? So in the armamentarium against EGFR mutant lung cancer, we have the first generation TKI, we have the second generation TKI, and we have the third generation TKI. We can use any of these in first line treatment. Next slide, please. So let me start off with third generation TKI, which is osimertinib in the first line. Next slide, please. So if we look at this, and this is what NCCN says, if our patient with lung cancer, their EGFR status is known prior to start of therapy, and if the patient has EGFR mutation positive, especially the 19 or the 21 subset, then osimertinib is a category 1 and a preferred treatment of choice. However, if we are not able to find the mutation status prior to start of therapy, the preferred way is to complete the first line of therapy and then go to the EGFR targeted TKIs. Next slide, please. So I think this slide sort of teases out the difference between what the first, second, and third generation TKIs that we have. So the first generation TKIs are geftinib and erlotinib. Second generation was afatinib. Third generation was osimertinib. The two significant things that I would want to point the attention is, one is the inhibition spectrum. The third generation TKI, which is osimertinib, is also sensitive against T790M mutations. However, the first and second generation TKIs do not confer sensitivity where if a patient has T790M mutation. That is one. The second is the ability to cross blood-brain barrier. The first and second generation TKIs have a minimal blood-brain barrier penetration. However, osimertinib has a significant blood-brain barrier penetration, and this is primarily because of the covalent modification of the ATP binding site of the EGFR. Next slide, please. So if we look at osimertinib, it is a third generation, irreversible, CNS active EGFR TKI developed to target both EGFR sensitizing and the EGFR T790M resistance mutation. So this works against the L858R, exon 19 deletion, and the T790M resistance mutations. And this crosses the intact blood-brain barrier, and this has been seen in human and preclinical models. On the leftmost corner, we can see that the activity of osimertinib in wild-type EGFR is minimal at best. Next slide, please. So the pivotal trial, which confirmed the role of osimertinib in first-line treatment with metastatic non-small cell lung cancer EGFR mutation-positive patients, is the Flora trial. So Flora trial is a randomized, double-blind, and all of these do hold some significance when, as I will point out in my later slides. Double-blind phase 3 study to test the efficacy and safety of osimertinib versus standard of care as first-line treatment in patients with locally advanced or metastatic EGFR mutant non-small cell lung cancer. Next slide, please. So this was a straight shot comparison between osimertinib at a dose of 80 milligrams once a day versus geftinib or erlotinib. Inclusion criteria here included stable CNS metastasis, which was something which many of the previous trials did not do. The stratifications was obviously exon 19 or the L858R subset, and significantly the stratification was race-based. It was just Asian or a non-Asian stratification, and there was no sub-stratification among Asians. Crossover was allowed if patients had a confirmed disease progression. The primary endpoint of Flora was progression-free survival. The secondary endpoint was objective response rate and overall survival, along with patient-reported safety outcomes. Next slide, please. So if we see over here, for the primary endpoint, the Kaplan-Meier curves started separating very early, and there was a very significant benefit with osimertinib over geftinib or erlotinib. The hazard ratios here were 0.46, which is something which was unseen or unheard of in the chemotherapy era. The PFS is a direct evidence of the drug's benefit, and Flora trial was covered to detect the PFS benefit. Patients who went on osimertinib first line had a median PFS of 18.9 months. That's over a year and a half on first line treatment of metastatic non-small cell lung cancer. versus 10 months in the standard of care arm. Next slide, please. These Flora plots are again, most of us trained with Flora plots of chemotherapy trials and the meta-analysis. But if you look at this over here, across every single subgroup, osimertinib was favored over the comparator EGFR, and this included patients who had a smoking or a non-smoking history, patients who had CNS metastasis at presentation, all other subsets. Osimertinib definitely did better than the comparator EGFR TKI. Next slide, please. Overall survival analysis was presented in the 2019 ESMO, and I was there when this presentation was done. Osimertinib for the very first time showed a median overall survival of more than 3 years in metastatic non-small cell lung cancer. And we need to look at this not from the light of the OS data of first generation TKIs, but more importantly from what was going on when we were training a lot earlier. Chemotherapy had a median overall survival of at best 8, 10, 12 months, almost never more than that. And here we are talking about more than 3 years, which is almost pushing the boundary of metastatic non-small cell lung cancer into a chronic disease territory. This was also the first time an EGFR TKI has translated the progression-free survival to a significant overall survival benefit. And the hazard ratio was 0.79 with a significant p-value over here. Next slide, please. The other important thing here is that, at the end of 3 years, when the study patients on the study were analyzed, nearly 30% of the patients were still on first-line therapy, compared to only 9% in the comparator arm. So nearly 1/3 more patients were still on first-line treatment even at the end of 3 years. And again, I'm talking about stage 4 lung cancer and not just any other hematological malignancy. Next slide, please. This is also very significant in terms of overall survival and also in terms of quality of life for patients. So the time to first subsequent treatment, and we all know that most often the first subsequent treatment is going to be chemotherapy. When patients received osimertinib was far better when we talked about the comparator EGFR TKI. Again, the hazards are very significant at a rate of 0.47 over here. Next slide, please. So if we try and compare all the first, second, and third generation TKIs, and both the first and second generation TKI trials use PFS as their endpoint. So if we just try and look at the various PFS of all the trials, IPAS and Optimal had PFS of about 9.5 to 13.1 months. Dacomitinib, which was also recently introduced in India, came out with a second best PFS of about 14.7 months. Osimertinib had an outstanding PFS of about 18.9 months. Next slide, please. Arun, next slide, please. Yeah, thank you. So when we looked at efficacy across various subgroups, the PFS was significant across every single subgroup. There were certain subgroups wherein the overall survival crossed the line of unity, but by and large, most of the subgroups, osimertinib showed a significantly better overall survival compared to first generation TKI. Next slide, please. The osimertinib PFS benefit was clearly maintained consistently across all subgroups, demonstrating its superior benefit across all population, including by race and across the different mutation types, which is important as we discuss overall survival subgroups. All OS subgroups did show a positive benefit in favor of osimertinib, although the magnitude of benefit varied. And this is consistent with the PFS data. Next slide, please. Next slide, please. Next slide, please. Yeah. So this slide basically talks about the real world evidence of using first generation TKIs. And the first data was by Dr. Patel's group from TMH, which showed a PFS of about 8.4 months and an overall survival of about 18 months. And geftinib was a drug used here. Dr. Robert Lewis's trial was published in 2012, and some of the patients I also had the fortune of following up. A small study, but then even this showed a PFS of 10 months in spite of including patients with peacock PS2 in the analyzing subset. The overall survival was not that different, but then again, the peacock PS2 the status could have made a difference over here. Next slide, please. Let's talk about the second generation EGFR TKI and then osimertinib. Next slide, please. So this slide is actually, it's a very educative slide, and this sort of compares the dacomitinib trial versus the osimertinib trial. So Archer 1050 was the pivotal trial for dacomitinib, and Flora was for osimertinib. If you see in the Archer trial, they had a strange race-based substratification of Japanese versus Chinese and other East Asians versus non-Asian. So that I felt was a little bit strange. The other thing was dacomitinib was compared only to geftinib, and erlotinib was not part of the comparator arm over here. When we look at Flora, the stratification was straightforward ethnicity-based stratification of Asian versus non-Asian. Next slide, please. This talks about the inclusion-exclusion criteria. Significantly, Archer excluded patients who had a history of brain or leptomeningeal metastasis, and it also excluded patients who had a suspected non-infectious pneumonitis or ILD, whereas Flora included patients who had stable CNS metastasis. Next slide, please. And this is something which I actually want to spend some time on because in the Archer study, if you observe the Kaplan-Meier curves, a little bit more in detail, the actual separation happened closer to 6 months. So for the first 6 months, there was no obvious difference between dacomitinib or geftinib. However, when we looked at the osimertinib versus first-gen TKI trial, the separation was almost immediate. It was seen almost at 6 weeks stage. So imagine at 6 weeks only, if we are able to demonstrate the superior efficacy of A drug over B, that just goes to show that patients can achieve the response that they want and that they crave for much earlier when we use osimertinib in first line. Next slide, please. Next slide, please. How to go forward, yeah? Yeah, yes. So if you look at this over here, in the Archer trial, overall survival was not statistically significant, and this was probably because the formal comparison of overall response rate was not hierarchically significant based on the study's hierarchical testing rules. So because the overall response rates was not significant, the overall survival analysis was also not statistically significant, and you can see the Kaplan-Meier curves cross in the Archer trial. But if we look at the Flora trial, this also showed this was the first trial to show the translation of a PFS benefit into overall survival benefit. Next slide, please. So this is a paper published by the Canadian Consensus Group, and this also said the same thing. The trial had a hierarchical stratified statistical design, and given that it did not meet significance in overall response rates, a p-value actually could not be assigned to overall survival. Next slide, please. So this is one slide which sums up all the characteristics of dacomitinib vis-a-vis osimertinib. Some of the issues that which may have cropped up in the Archer trial include patients with history of brain mets were not included. The median PFS in dacomitinib was probably a little lesser, although cross-trial comparisons is never fair. A very significant thing was the Kaplan-Meier curve separated after 6 months. So till 6 months, there was absolutely no difference between the first-line medicine and the comparator medicine. When we look at the dose reductions, nearly 66% of the patients on the Archer study needed dose reductions, and we all know that quality of life is probably a very significant indicator for clinicians who are treating metastatic non-small cell lung cancer. So compared to osimertinib, where the dose reductions are only 3%, I think the tolerance is also a major issue with dacomitinib. Next slide, please. Sort of trying to compare the LuxLung and the Archer data over here. LuxLung 7 compared afatinib versus geftinib, and it failed to prove overall survival benefit. We know I've already spoken about the Archer overall survival issues. Next slide, please. So this slide, let me give a caveat that cross-trial comparison without a head-to-head comparative study is never fair. But if you look at the Lux Lung 7, which included patients who had stable brain mets, the curve separation happened almost at 1 year. Archer took 6 months to show a significant benefit over the comparator. Flora took only about 6 weeks to show a significant benefit over the comparator arm. Next slide, please. I keep coming back to brain metastasis, and that's very important. Let us look at brain metastasis. Next slide, please. Osimertinib is the ideal treatment option for patients with EGFR mutated lung cancer with stable CNS mets or at risk of stable CNS mets. Next slide, please. So the reason is that the brain is actually a sanctuary site after an initial response to EGFR TKI therapy. Isolated CNS progression can occur due to poor EGFR TKI penetration, and the blood-brain barrier limits drug penetration to subtherapeutic doses, allowing the regrowth of the EGFR mutant disease. Next slide, please. So preclinical studies indicated that the first and second generation TKIs were poorly distributed in the brain and the cerebrospinal fluid. However, osimertinib is blood-brain barrier permeable. Next slide, please. Osimertinib has demonstrated high brain penetration. In Flora trial, both systemic and intracranial efficacy were separately analyzed. Osimertinib showed superior efficacy to erlotinib and geftinib in the central nervous system. Efficacy in patients with brain metastasis was not investigated in erlotinib or geftinib global clinical trial program. In the Lux Lung 3 and 6 studies, afatinib showed a significant improvement in the systemic response compared to chemotherapy. However, neither study assessed the intracranial response from treatment. So, osimertinib is the only EGFR TKI to be powered to report intracranial efficacy. Next slide, please. Aru, next slide, please. Aru, can we move to the next slide, please?
The slide's not changing.
Aru, can you go to the next slide now?
Aru, is the screen frozen or?
Right now I am on Flora.
So
CNS progression.
yeah. So this is Dr. Aditya, sir, can you hear us? Aditya sir, can you hear us, please?
Hello.
Yeah, Aditya sir, can you hear us? So you are at Flora now, CNS progression on first line.
Okay. Yeah. Okay, great, done. So this slide talks about the CNS progression on first line alternative versus standard of care. So we know that patients who went on the first line standard of care EGFR TKIs, nearly 43% of the patients progressed only in the CNS, and that is a significant number, and that was brought down to nearly 19% when patients went on osimertinib. Next slide, please. Yeah, so when we look at treatment options for patients with newly diagnosed brain metastasis, NCCN talks about certain guidelines. If any non-small cell lung cancer is the primary, and if the patient is PD-L1 positive, we do pembrolizumab in first line. If patient is ALK positive, then alectinib is the first line option. If patient is EGFR positive, then osimertinib is the first line option. Brigatinib and ceritinib has also shown intracranial efficacy in ALK positive patients. So NCCN has also reaffirmed the data which has been shown in the Flora trial. Next slide, please. So let me close this session by talking a little bit about the tolerability profiles of EGFR TKI. Next slide, please. Next slide, please. Yeah, so this is something which I wanted to see, and this looks at the adverse event summary of Flora trial. So although about 60% of the patients had some diarrhea in when they took osimertinib, the amount of grade 3-4 diarrhea was very, very less. It was just about 3%. This also means that the number of discontinuations or interruptions due to adverse events was significantly less when patients went on osimertinib. This also holds good for the skin-related side effects of rashes and acne. So we can see that when we use the first generation TKI, the side effect profile was definitely far worse compared to osimertinib. Next slide, please. So dependent on the adverse event duration, this slide sort of sums up the adverse event profile in the Lux lung, which showed that 41.9% of the patients needed some kind of dose reduction when they were on the afatinib trial. 66% of the patients needed some kind of dose reduction when they were on the Archer trial. However, only 4% of the patients needed some sort of a dose reduction when they were on the Flora trial. Next slide, please. And finally, we need to talk about adverse events leading to death on trial. Unfortunately, Archer had nearly 22 patients, that is 10% of study population, who died only due to adverse events. Compare this to Flora trial, any adverse event leading to death was only 2%. Next slide, please. There was some exploratory analysis which was done for documentary and geriatric use, and this also led to a lot of those interruptions and those discontinuations. Next slide, please. So the synopsis of why we think it is important for patients to receive first-line osimertinib is, next slide, please. If we see in this slide, and this is very significant, if we use osimertinib in the first line, then we know that the second line is going to be chemotherapy, and there is a reasonable percent of patients who receive chemotherapy in the second line. However, if we use the standard of care osimertinib, standard of care TKI in the first line, 1/3 of the patients end up developing T790M mutation, and in them we can probably use osimertinib. However, 1/3 of the patients are not fit to receive any second line therapy, and this is probably due to a drop in PS or due to death, which means that the benefit of osimertinib did not reach at least 1/3 of the patients. There is another 1/3 of the patients in whom the T790M status was unknown, so we cannot exactly say that we need to save osimertinib for second line. So what this slide sort of tries to say is that 1/3 of the patients do end up dropping out and may never be able to receive the best EGFR TKI that we have today. And the whole idea of saving osimertinib for second line is worth it only for 1/3 of the patients. Next slide, please. Next slide, please. So 1/3 of all EGFR mutant patients treated with the first second line TKI are able to receive second line treatment. 7 out of the 10 patients who started on the first second generation TKI will not be able to receive osimertinib in the second line, and unfortunately our biomarker studies have not yet progressed to the extent that we will not be able to predict who will develop T790M and who will not. So the whole concept of sequencing TKIs in metastatic non-small cell lung cancer is still not yet completely mature. Next slide, please. Geotag is actually a very interesting study, and this was talked about in, this was published in 2019, and this generated a lot of discussion on the sequencing of TKI agents in EGFR mutant lung cancer. So this was a study which looked at sequential afatinib and then osimertinib in patients with EGFR mutant non-small cell lung cancer. So this was just an observational study. Next slide, please. So if we look at the Kaplan-Meier overall survival curves over here, Geotag suggested that osimertinib for second line after failure on a TKI may have resulted in a better overall survival. And the median OS for patients who were observed in Geotag study was 41.3 months, which was potentially better than the 38 months seen in the Flora study. However, it is important to note that Geotag was a retrospective analysis. Next slide, please. Yeah, so Geotag was a retrospective analysis. It was an observational study. Patients who had T790M, negative were probably excluded or not tested. And unfortunately, this study, and this is one of the biggest problems which I have with the Geotag study, is that This study did not include patients who died on first-line afatinib or patients who could not receive second-line therapy. So that obviously would have skewed results. That was the first problem with geotype. The second problem with geotype was the endpoint was time to treatment failure. Now, time to treatment failure is a completely different endpoint when we talk about PFS. And PFS has for a long time sort of been the standard when we talk about metastatic cancer patient studies. So time to treatment failure is not as robust an endpoint as it was progression-free survival. So it is not possible to draw conclusions about relative benefits of sequential afatinib osimertinib versus first-line osimertinib without actually a direct head-to-head comparison trial. Next slide, please. So to sort of summarize, starting with prior EGFR TKIs and then treating those that develop T790M with osimertinib may not yet be optimal because we are not yet smart enough to figure out who will get the EGFR T790M and who will not. Not everyone will be well enough to receive additional treatment, and nearly 30% of the patients actually end up receiving no subsequent therapy. Tissue and liquid biopsies are not always successful, and especially in our own setting, we know how much we struggle every day with doing biopsy in the second line setting, or for that matter, even getting liquid biopsies. Osimertinib is the only EGFR TKI which has been associated with the overall survival benefit. Next slide. So osimertinib demonstrated a clinically and statistically significant improvement overall survival. The median OS of more than 3 years does set a new benchmark in the management of patients with stage 4 non-small cell lung cancer with sensitizing EGFR mutation. Flora was the first time when the EGFR TKI had a PFS benefit which translated into OS benefit. Very, very significantly, nearly 30% of the patients remain on osimertinib even at 3 years, and across all subgroups, there was a positive benefit. With additional follow-up and increased treatment exposure, the safety profile of osimertinib remains consistent with previously reported data. So at least in my own clinical practice, osimertinib is the standard first-line treatment for my patients with sensitizing EGFR mutation lung cancer, especially exon 19 or the L858R mutation. Thank you all for a patient listening, and I close my presentation here. Happy to take any questions.
So thank you so much, Dr. Aditya sir, for such a eloquent and brilliant presentation as always. So can I have a request, Dr. Poonam Patil ma'am, if you're there, if you have any question, and then followed by Dr. Sood sir.
It was indeed a very good presentation, and also knowing the background that you are on your journey to Delhi and you have given this presentation from airport. Really very good presentation, Dr. Aditya. I don't think so anybody else would have been able to do justice the way you did to this
Thank you,
topic.
ma'am.
Okay. So I don't think so there are any questions in the chat box. So,
but ma'am, any question from your side or Dr. Sood before before Dr. Aditya take a flight to Delhi? Sir, Delhi would be by the time you land, it will be 9 degrees. So it's bit. So
I know yesterday was the coldest evening in Delhi. Yes, correct.
Correct. Okay. So Dr. Rahul Sood, are you there? Any questions from your side, or we close the session and we move to next one?
Yeah, I have only two questions actually for Dr. Aditya. So, Dr. Aditya, what is your treatment of choice in first line in case the patient is having EGFR mutant lung cancer? Is it the PEM carbo plus geftimnib, or would you go for osimertinib? Patient doesn't have any brain mets. So how do you choose between them?
So irrespective of brain mets, Dr. Rahul, we do choose osimertinib, or at least we offer them to all patients in the first line, and I'm not talking about the logistical challenges over here, and that is primarily because we want to reserve chemo for the second line. And as I have said, about 1/3 of the patients who received the PEM carbo geftimnib or who are on any of this, they almost never received any second line treatment at all. So if there's a more powerful drug, it probably is not fair to reserve it for a second line, and we would want to use it in the first line. When would I use PEM carbo geftimnib? Probably only if there are logistical constraints. Apart from that, almost never would I use a combination of chemo TKI in first line.
So what is your second line in case the patient progresses on osimertinib? And we've seen it very often. People do, there are fast progressors also, or even on osimertinib.
So we try and do biopsies when patient progress, at least liquid biopsies. In most of them, we try and get. We don't know who has a MET exon 14 skipping mutation. At least we are hoping to find that one MET exon 14 skipping mutation, because we have a TKI now, and we look for it. I've not found any till now. But if that is available, or if there is any target that we can do, we try and target. But otherwise, it's going to be PEM carbo only, second line.
Right. Last question, and nothing to do with medicine. Why are you leaving Bangalore's weather and going to Delhi with horrible weather, horrible air, and higher number of COVID patients?
Purely because the hospital which gave me my first job is where this event is happening. So purely out of personal reasons.
Right. Bon voyage and have a very nice flight.
Thank you. Thank you so much, Dr. Aditya, sir. And we take the things forward. It's a great pleasure to welcome Dr. Neeti Razada, ma'am. Good evening to you, ma'am. So Dr. Neeti Razada is a director of medical oncology, hemato-oncology and transplant at Fortis Hospital, Bangalore. Ma'am, good evening. And we request you to share your slides. Ma'am is going to talk on new paradigms in the management of ENSCLC, focusing on ADAURA.
Thanks so much, Tarun. Thanks, AstraZeneca, for having invited me today. And thanks, Dr. Rahul and Dr. Poonam for inviting me too. So this is the landmark trial which got FDA approval for using osimertinib in the adjuvant setting, the ADAURA trial. And I'll try to make a brief presentation on the same. Aditya has updated significantly on the use of TKIs. So I'll try to keep it brief. So the data suggests that 1 in 3 patients of NSCLC actually present with resectable disease. I don't know whether we have a similar data, but well, this is what is the international global stats. And lung cancer, as we know, is the most common cause of cancer death, with about 2.21 million patients dying annually of this disease, which is very close to breast, which is about 2.23 million dying annually. And NSCLC represents the most common type of lung cancer. And as I said, 30% of this, as per this report, was resectable disease. And we have localized disease, that is stage 1B, and then stage 2, and then stage 3A, which is what I'll be talking about right now. So the outcomes, if a good surgical resection is performed, is relatively good in early stage NSCLC. And adjuvant cisplatin-based chemotherapy is the recommendation for resectable stage 2 and 3A and selected 1B patient. And normally the adjuvant includes 4 cycles of chemotherapy. And the results show that the 5-year overall survival is quite good in such patients, with the overall survival and disease-free survival in the tune of almost 76% in all the 3 categories. And talking about EGFR mutation, broadly, we know that it is commonly seen in about 30 to 40% in our population, more commonly in East Asians, but in India as well, about 27 to 30% of the patients would be EGFR positive. When we talk about Taiwan or Chinese or Japanese population, about 40% of them will be positive. However, Caucasians will have a relatively lesser presentation. That is only about 10 to 20% of such patients would have EGFR positivity. This EGFR positivity does not seem to change with stage. And from stage 1 to stage 4, there's relatively similar presentation in terms of EGFR positivity. Now, this is the ADAURA trial, which I'll be talking about here. This is osimertinib used as an adjuvant therapy with stage 1B, stage 2, and stage 3A, EGFR positive, mutations positive NSCLC, who have actually undergone surgery because they were medically fit and they have a tumor which was resectable and underwent a complete tumor resection. This study was conducted in about 234 study locations. And the primary completion was in January of 2020. So the data which I am presenting was presented in 2020 ASCO, that is June 2020. And the final analysis will actually come up in 2023 when all the data would be analyzed. So this was a preliminary data which already showed good results, and which is what I am presenting here. And this led to an FDA approval of use of osimertinib in the adjuvant setting. So what was the key inclusion criteria? This was a phase 3 multicentric study. It was a double-blind study in which osimertinib was used in the dose of 80 milligram once a day in one arm, randomized 1:1, and the other arm was placebo arm. The total number of subjects were about 682. The inclusion criteria were patients who were more than 18 years. Actually, interestingly, they have given a cap of age of 120 years in this study. So the patients between 18 and 120 years age. And in Japan, the recruitment was only the patients who were more than 20 years of age, who were in good performance status, that is 0 and 1. They had confirmed histology of non-squamous cell, who had either an exon 19 deletion or L858R with or without T790M mutation. And all patients had a brain imaging and did not have brain metastasis at presentation. If it was not done before, it was repeated before starting the trial. And the maximum interval between surgery and randomization was 10 weeks if no adjuvant chemotherapy was used, and it was 26 weeks if adjuvant chemotherapy was used post-surgery. Stratification was based on 3 major criteria. One was the stage, that is stage 1B versus stage 2 versus 3A, whether they had exon 19 deletion or L858R, or whether they were Asians or non-Asians. The primary treatment duration was 3 years, and the treatment continued until disease recurrence, treatment completion, or they had completed the 3-year period or discontinuation criteria was met. And the follow-up was done until recurrence at week 12, 24, and then every 24 weeks thereafter till about 5 years. So as I said, that most of them had a central confirmation of exon 19 deletion or L858R mutations. They could have T790M in association with it, which was MRI was done at baseline, and it should be MRI negative in all cases. The exclusion included medical history of interstitial lung disease, other than the routine exclusions. All the baseline characteristics were matched in the overall population based on gender, the age. Asians were predominant. Almost 65% in both the arms were Asians. Most of them were non-smokers, that is 68% in the osimertinib arm and 75% in the placebo arm. It was actually based on AJCC 7th edition, not the 8th edition, which we use now. And 96% and 95% were adenocarcinoma. So these were the results which showed a remarkable divide in Kaplan-Meier curve, with the primary endpoint being disease-free survival, significantly in favor of the osimertinib arm in stage 2 and stage 3A, with a hazard ratio of 0.17, which was statistically very significant. When we combined all the 3 stages, that is stage 1B, stage 2, and stage 3A, well, the hazard ratio was still significant, with p-values being good, but at the same time, a little less than when stage 1B was not included. This benefit was seen across all population, whether it was smoker population or non-smoker, based on whether they were Asians or not Asians. So as you can see this, the benefit was slightly less in stage 1B, but stage 2 and stage 3A had a remarkable benefit. This is the snapshot of overall survival. Well, the trend is in favor of osimertinib arm, but not good enough to quote overall survival data benefit. And this is basically the summary of all the trials which have been done in the adjuvant setting using a TKI, and which were first and second generation TKI. The SELECT trial used erlotinib from stage 1 to stage 3A and said that there was an overall 2-year disease-free survival of 88% versus control arm, which was 76%. Radiant trial again used erlotinib versus placebo, which had a clinically meaningful DFS improvement in EGFR mutant group, that is 46 months versus 28 months. IVAN trial again used erlotinib with a significant disease-free survival. The negative trial was BR19 trial with the use of geftinib, in which no DFS and OS benefit was noted. So in conclusion, adjuvant osimertinib as a first-line targeted agent in this global trial showed statistically significant and clinically meaningful improvement in DFS in all stages, that is stage 1B, stage 2, and stage 3A, completely resected EGFR mutated NSCLC. let me just talk about one subset, which seems to be our focus here. That is the CNS disease recurrence in the presence of treatment with osimertinib. So this was the same trial, but it had a pre-specified exploratory analysis to look for disease recurrence patterns, which also included disease in the CNS. So we all know that the type of recurrence is the key consideration when we are considering the subset of population with resected NSCLC. And if there's local recurrence, the patient outcome is relatively much better than if there's a systemic recurrence. The CNS is a common sanctuary site, as Aditya mentioned, and a common site of distant recurrence amongst patients who are EGFR mutation positive, receiving EGFR TKIs, as seen in all the trials with adjuvant erlotinib, that is adjuvant radiant trial. 37 patients had recurrence in the CNS with erlotinib. Then osimertinib has definitely known to have a clinical significant response in brain compared to other TKIs and a greater penetration of the blood-brain barrier. So the type of recurrences which were noted here was that 11% of the patient in the osimertinib arm had a disease recurrence or death versus 48% in the placebo arm. So there was, like, as you can see, a large divide. In the osimertinib arm, the majority of patients had only local and regional disease, with only 38% of the patient of this osimertinib subset having metastatic disease compared to 61% of the patient in the placebo arm. Now, this is the distribution of patients who had disease recurrence. So local disease recurrence was seen in 11 patients in the osimertinib arm. Lung only recurrence was seen in 6 patients. CNS was seen in only 1 patient out of all the 339 patients who were analyzed in this study. And when you look at the overall number, 45 patients in the entire study had CNS events, out of which only 6 patients in the osimertinib arm and 39 patients in the placebo arm had a disease recurrence in the CNS. This was the CNS disease recurrence and death rate. Osimertinib arm actually reached almost 100% survival with no disease seen in most of the patients. So as I said, 2% of the patient has CNS disease. And as far as the safety of osimertinib is concerned, we all know it's very comparable to all the TKIs, probably much safer and most of the first and the second generation TKIs. And all in the entire study, all grades of AE were seen in almost 97% of the patient. 20% of the patient had grade 3 and above AE with no deaths related to the adverse events. When we talk about osimertinib correlation, only 10% of the patient on the osimertinib arm actually had side effects related to osimertinib with no death in relation to the same. Again, this is a slide which Aditya already presented, that the most common side effect includes diarrhea. Paronychia is seen in some patients, dry skin and pruritus is noted in some, cough, stomatitis and nasopharyngitis is seen in some patients. What we have to know is that grade 1 to 2 interstitial lung disease is seen in about 3% of the patient in osimertinib arm, and QTC prolongation is noted in about 7%. But all this QTC prolongation seems to be inconsequential, although we still need to record the event regularly. So in conclusion, the reduced risk of local recurrence and distant recurrence and improved CNS recurrence rate and death and reinforce that adjuvant osimertinib is highly effective, a practice-changing treatment in stage 1B, stage 2, and stage 3A EGFR mutated NSCLC following complete tumor resection. Thanks so much.
So thank you so much, ma'am, for such a brilliant presentation. So can we have Dr. Sood some questions, and anybody from the audience if they have some question for ma'am, because we have some time. Dr. Sood, you are there, please.
Thank you, Dr. Neeti, ma'am, for a very nice presentation. Dr. Neeti, do you think is it a practice-changing practice, or are you using osimertinib in your practice for early lung cancers who've been resected EGFR positive?
Honestly, Dr. Rahul, until now I was not using, but this is a practice-changing trial, and at least we can quote this trial to justify our usage. But at the same time, I think at least in our country, cost still remains an important consideration. We have good data with erlotinib as well. So we should justify
Yes.
whether, at least in stage 3A, yes, we should consider an adjuvant therapy.
Right.
Stage 1B
Right.
could be a gray area, but stage 2 and stage 3A, definitely we can consider some kind of an adjuvant therapy.
Yes, yes, very true. Only issue is if later on the patient metastasizes while
Then
on
options are-
osimertinib, then actually we have already challenged the third generation TKIs, and then I don't know what we are left with thereafter.
Absolutely.
Whether giving a first or a second generation TKI to such a patient after osimertinib, it remains another thought altogether. So this is one thing that probably even nobody has an answer for, but something to think about, right?
Completely agree.
Okay, wonderful. So since we also have some time, so Dr. Sood, sir, with your permission, can we go for a panel discussion? I think we can have a sufficient time there. It's a pleasure to invite Dr. Rahul Sood, Head of Department and Senior Consultant Medical Oncology at Command Hospital, Air Force Base, Bangalore. Sir, good evening to you. By the time you come up with your slides, let me invite the panel, esteemed panelists. We have Dr. Rohan Baise, Consultant Medical Oncologist from KLES, Dr. Prabhakar Core Hospital, Belgaum, Karnataka. We have Dr. Rudrash with us, Assistant Professor, Medical Oncologist, Kidwai Memorial Institute of Oncology, Bangalore. We have Dr. M.S. Vishweshwara, Chief Consultant, Radiation Oncology, SCG Bharat Hospital and Institute of Oncology, Mysore. And of course, pleasure to have Dr. Rajiv Alke with us, Consultant Medical Oncologist from Kidwai Memorial Institute of Oncology, Bangalore. Unfortunately, Dr. Vijit Shetty will not be able to make it. So you have your complete rest of the panelists are available. Over to you, Dr. Sood.
Right. One sec. Yeah. Are my slides visible?
Very much, sir.
Yeah.
Yes. Right. So Tarun, I just need a revision of the panelist. Dr. Rohan Baise is a surgical oncologist.
Medical oncologist.
Medical oncologist.
Medical oncologist. Hi, Dr. Rohan. Dr. Rudrash is a medical oncologist.
Yes.
Right. Dr. Vishweshwara is also a medical oncologist.
No, he's a
I'm a
consultant
radiation oncologist.
Radiation oncologist.
Yes.
And Dr. Rajiv is a medical oncologist.
Yes. So can we request all the panelists to switch on their videos and then we will mute everyone. Sir, over to you, sir.
Right.
Rahul, you don't have any surgical oncologist.
Surgical oncologist.
Yes. So I was going there itself, and I somehow slyly have invited my surgical oncologist. I don't know whether I can cajole him to join. If Wing Commander Dr. Raj Mohan is there,
Sure.
could I just request him to join in? Wing Commander Raj.
Yeah, whatever I can pitch in, I'll do. I'm not.
So nice of you, Raj. This is a topic that will interest you also. So I'll just start here. So I'll not go to this slide because we've already heard about it. We know about the incidence. We know about the mortality which is there. And once again, the lung cancer, the leading cause of death, leading cause everywhere. So 5-year overall survival. As the stage goes beyond the Lakshman Rekha, that is the stage 3B, it becomes even more dismal. So this is the 5-year overall survival. Stage 4B is 0% of resectable NSCLC. So I'll start with now the surgical oncologist itself, since Rajmohan is there. So Vinko Rajmohan, how often do you see patients of stage 1, stage 2, and stage 3A in your routine clinical practice? And I know they come to you first and then to us, that is the medical oncologist.
Yeah, to be very frank, even when I was a trainee in All India Institute and even now, the number of early lung cancer in India continues to be very low. On an average, if we see maybe around approximately in a month in our hospital, for example, if you see maybe around 5 to 10 CL lung cases in a month. Hardly we get 1 to 2 of them in early stage, which looks resectable to us. That is confined to lung, maybe N1 disease or maybe an early N2 disease. Even during the training time in All India Institute, the numbers were similar. Most of them were quite at least an N2 stage disease. So it is very less. Yeah, less than 30%.
So what do you think is the reason that we don't get stage 1 and stage 2 very often? Is it the awareness? Is it the screening? What is the reason, or is it the biology of the disease which manifests in the form that the patient comes only at stage 3A or probably stage 4? Why not stage 1 and 2?
Yeah, as you said, the reasons are multifactorial. It cannot be pointed out to one reason, like maybe in breast cancer. There are multiple reasons. Definitely one of them is less awareness. And yeah, even smokers who know that a bad cough is not a good sign still are in peripheral centers are still diagnosed first as tuberculosis, bronchiectasis, COPD, lung masses. So yeah, reasons are multifactorial. Most common reason is the confusion with tuberculosis and delay from patient side only.
I think I can't agree with you more on that. The same question to Dr. Vishweshwara. I'll just twist it a little bit. So you're a radiation oncologist, and in your practice, you're also involved in treatment of early stage lung cancer. So same question, and a caveat to that is there any role of low dose CT for screening high risk patients in our practice these days? We kept reading it in Devita again and again.
Definitely. Yeah. As I said, we are seeing in later stages only. Even though smoking may be a habit seen in the West also, and even in Singapore, East Asian countries also, but they screened and they're informed and they're more aware, as I said. That is not there in our country. And as I said, delay in diagnosis. And definitely the insurance and other things should take up, and low-dose CT scan has to be adopted to our health policy so that they can be picked up at an early stage. I'm very much positive for that. Yes.
Right. Similar question again to our medical oncologist. I'll start with Dr. Rohan. Any cases we picked up during the COVID times, early stage lung cancers?
No, sir. We picked up cases, but they were all advanced lung cancers.
Right. Dr. Rudresh, your practice?
Yeah, in last, not in COVID, last 12 years, I seen only one case, stage 1B.
Right. So
most of the patient, our patient will be presenting with N2 lymph nodes.
Right. So Dr. Rudresh, staying with you itself, so do you insist on clinical staging or invasive pathological staging? So when I mean clinical staging, I mean not just clinical, but also the CT scan, or is it the invasive pathological staging that is there? So what do you do?
Yeah, clinical staging for all the patients we are doing.
Right.
Either CT scan or CT scan. And what do you mean by invasive pathological staging?
Invasive means for obviously the mediastinoscopy or biopsy-based staging.
The invasive mediastinoscopy, I think surgical oncologist may be better person to answer. But yes in borderline case, if PET CT scan, when we done, if any doubtful mediastinal lymphadenopathy, it should be confirmed with mediastinoscopy. But in PET CT scan, if it is very clear cut, I don't think any mediastinoscopy is required.
Right. So I'll go back to our surgical. Please.
This is what we do in our hospital also. We take up for PET CT for all the patients of CL lung and make sure there is a mediastinal disease or contralateral mediastinal, hilar or hilar. So if it is obviously high SUV taking up lesions, and our surgical oncologist would take a call. And doubtful lesions, mediastinal biopsy or EBUS, or in fact EUS also, biopsy also, we have referred to gastroenterologists to do the FNAC, and we have got a quite promising results in that. So we don't do mediastinoscopies, but we restrict to EBUS and EUS.
Right. So Vinko Rajmohan, your points on this question, invasive pathological staging in the era of PET scan?
Yeah, and Dr. Rahul, I fully agree with Dr. Rudresh and Dr. Vishweshwara. We also would go for a PET CT upfront for CA lungs, and only in borderline cases, like not borderline would be N2 disease more than 3 centimeter node, bulky nodes, multiple station involvement. We should, there is no need, we will not go for a mediastinoscopy. Only for a borderline N2, like less than 3 centimeter nodes, maybe 1 station node, then in those cases, even in those cases, we would like to go for an EBUS FNA rather than a mediastinoscopy now.
Right. I think I'll agree. I'll agree with you. Now we come to this typical tumor board type of questions, and I'll start with Dr. Rajiv on this. So, Dr. Rajiv, the first set of questions are for you. How would you manage a stage 1B patient? The patient has come to you.
Yeah. Stage 1B, it is operable both by disease factor and patient factor. Surgery is the ideal thing. If any case it is, if it is any case, surgery is not feasible, then we will go with SBRT. But the third option, I don't think stage 1B you can have. As such, it is a small subset. Even though Dr. Niti quoted 1/3 are operable, but we don't see so much cases. So I don't think the third option we can get into that.
So adjuvant chemo in stage 1B, have you ever given? Are there any high risk patients where you think of adjuvant chemo? Or
yeah, more than 4 centimeter we will give adjuvant chemo. That fits 1B. But I have not given any patient with that. I have not seen.
Right. So what is your treatment of choice in case you want to give adjuvant chemo for such a patient in stage 1B?
Yes, 4 centimeter tumor.
Yes. A patient is high risk and you want to give him an adjuvant chemo. So what would be your treatment?
It's a platinum doublet.
Right. Okay, fine. So we had data from the Anita trial, but I don't think we don't use vinorelbine these days.
Yes.
Right. So I agree with you. But so the second scenario, how do you manage a stage B? So I'll go to Dr. Rohan straight away on this. And again, the patient has landed up with a medical oncologist. So what do you do in a stage 2 disease?
Sir, if he is operable, okay, so I would consider surgery followed by adjuvant chemotherapy in majority of the cases. Inoperable, I would rather consider, because we don't have facilities for SBRT, so I would consider CTRT in inoperable cases. Followed by adjuvant.
Right. I think I'll agree with you, but I'll take the inputs from a radiation oncologist on this. So what would you do, sir?
SBRT is as I said, SBRT is a new tool. It's a new toy or new game for radiation oncologists. Still, I feel a lot of learning curve should be required because if you miss and little bit, if you go haywire, you're totally, especially central tumors and ultracentral tumors are not amenable for SBRT. A little bit of this thing goes to trachea and aorta, he dies the next day. So only thing to be minimally kept it for peripheral lesions. Peripheral lesions, 5 centimeter, keep them this thing, upper limit, 4 centimeter lesions without nodes, definitely SBRT is an option. But still, I feel a lot of learning curve is required in this technique. And then we can master that, what do you call, targeted killing, that it is kind of targeted treatment. But these are the two important things where we should avoid for central tumors and ultracentral tumors. So that is the one thing. Of course, we are not, until then, I think we need to go ahead with IMRT, which was not practiced earlier, because without IMRT, we had a lot of radiation pneumonitis, radiation cardiotoxicity, things like that. Nowadays, no longer we are seeing that. When we go for a curative intent, our side effect profiles, adverse effects should be minimal.
Right. Dr. Rudresh, new adjuvant chemotherapy, stage 2?
Yeah, platinum doublets.
Okay. Is it a popular choice? Is it a popular choice, stage 2?
See, we are seeing very less case in practical this thing.
Right.
I told no last maybe 8 to 10 years, I given only one case, adjuvant therapy. That also not vinorelbine. Actually, I given PEM and cisplatin. But yes, the standard of care in stage 2 is to give the adjuvant chemotherapy post surgery.
Right. Absolutely. So I'll ask my surgeon again. Raj, are you more favorable in giving radiation upfront or a neoadjuvant chemotherapy and then taking up for surgery for a stage 2 disease? So what is your preference?
Yeah, here tumor biology takes a big this thing. CA lung is an inherently aggressive biology. So surgeons, we have burned our hands many times operating upfront. So the moment I see a CA lung, other than of course we don't see much of 1B, stage 2 or stage 3, I would always prefer to give neoadjuvant. That has been my teaching also. At least 2 to 3 cycles of neoadjuvant chemo only, followed by reassessment and surgical planning. Radiation, no, not as a routine before surgery. It increases the morbidity, and so only chemo, neoadjuvant chemo.
Absolutely. I think we are slowly shifting. So the third part, I think this has a contribution from all three, because this goes to a tumor board stage 3A, and I think the surgeon takes a call on this regarding the resection, whether surgery can be done or not. So it is between a neoadjuvant versus a surgery. So Dr. Vishweshwara, any role of radiation, NACCRT in stage 3A disease?
If it is operable, we don't give any kind of pre-op RT. Let them go ahead with surgery. Then if required, definitely N2 disease, we'll go ahead with post-op RT. But when it comes to stage 3B, everybody knows the standard of care is concurrent CTRT.
Right. I think majority of our patients receive some neoadjuvant therapy for stage 3A. So Dr. Rajiv, neoadjuvant chemotherapy, stage 3A?
Yeah, what I want to comment is, see, whatever the stage grouping is there, but it is most of the time it is a tailored to the patient, because T4, N1 also stage 3A. So T4 they will not operate. That will be a difficult subset, and even for the chemo also sometimes, I mean radiation also, they will not consider radiation because of the major vessels or even the cardia involved. So sometimes the neoadjuvant is always we go with neoadjuvant, and sometimes the sequential CTRT is also we consider in these subsets.
Yes, absolutely. And I think we tailor it and discuss it in a tumor board, and we individualize it. So I think the tumor board has the maximum importance in such stages of the disease. So just moving forward, the Anita trial, nothing new about it. Vinorelbine plus cisplatin, we now usually give platinum with taxane-based chemotherapy. So this was the first trial for NSCLC, and the lung adjuvant cisplatin evaluation, which was the LACE trial, again showed that there was a benefit which was seen, which decreased as the stage went forward. So this is again, the benefit was higher in stage 1B, but that itself, the subset itself was good, and the earlier stage as it went forward. So next question is, what would you do in case the patient refuses surgery, or if combined condition prohibits surgery in a case of early lung cancer? So I'll start again with Dr. Rohan with this. What do you do in such a patient? Dr. Rohan is there. Am I audible? Hello.
So Dr. Rohan is not there.
Okay. So I move to Dr. Rudresh on this.
I think these are all the cases where we should advise SBRT rather than all the cases. So patient refuses if lot of comorbidities. So SBRT in very early stage has shown benefit.
Right. I think radiation has a role in
radiation is having a role in this subset of group.
Yes. And try to convince him for surgery later on. And so what about, could you comment on R0 resection? How often is it achieved in practice? And since I have only one surgeon, so I'll ask Wing Commander Raj Mohan on this. R0 resection in your practice, up till what stage or up till what nodes are you able to get an R0 resection? In fact, we would like to learn from you which subset gets an R0 resection.
Yeah, Dr. Rahul, as Dr. Raji very rightly pointed out, that even among resectable or so-called stage 2 and stage 3 lung cancers, it's a very heterogeneous group. There are groups where there are patients with T4N1 which are staged as stage 3, resectable, considered resectable. So it's a very difficult call, no doubt on that. In fact, rather than going on R0 resection, one of the first concern for a surgeon nowadays, at least the thoracic oncologist, is that we should try to preserve as much lung parenchyma as possible. So the first principle we would go for is avoid pneumonectomy at all costs, at all costs for a CL lung. So to avoid pneumonectomy, many of these cases would require neoadjuvant. We would always try to go for a lobectomy, either a bilobectomy or a removal of one lobe. At all point, avoid pneumonectomy. If the patient would require pneumonectomy, in fact, we'll go for a definitive CCRT modality. R0, yes, if appropriately selected well, a good number of patients will do it. It all depends on patient selection. If you selected your patient well, given neoadjuvant chemotherapy, you can achieve a good, during my training time only, I can say, because I have not done so many resections right now. We used to have a good R0 resection rate, close to more than 80% would have a good R0 resection rate. And the lesser the chance is when the nodes are more bulky. More than 3 centimeter nodes are always a risk factor for leaving residual disease behind. Less than 3 centimeter and 2 nodes, good chance of an R0 resection.
Right. So now caveat to that, 3B resectable. I don't think so 3Bs are ever resectable. What about your practice? Vinko, Raj, for you only.
No, we would, yeah, it's again, it's a tumor board decision. We would not consider.
I think 3B are ideal candidates for definitive CCRT, or probably very few of them go for any CCRT followed by surgery. I think we all will agree. So Dr. Rajiv, 3B disease?
Yeah, as I already mentioned, see again it goes T2, N2 can be considered. N3 again, N3 supraclavicular is there, it cannot be operated. So again T4, N2, again it is a difficult call for the surgeon. So as Rajmohan rightly pointed out, it is, so only small subset will go for the surgical thing. We mainly consider CTRT in these subsets. I have not seen my surgeons operating 3B.
Right. I agree. So a patient upfront surgery, R1, R2 resection done. So Dr. Vishweshwara, what would be your next treatment for this patient?
Yeah, in such patients, definitely if it is stage 3, N2, if the N2 disease was there, then definitely add a post-operative radiation therapy. But only the caveat is there, only it has shown improved DFS and overall survival was not shown in the LUNGA trial also. But there was a negative thing. Why? Because proper radiation techniques were not used those days. And major problem was the radiation-induced cardiotoxicity. So, but now I feel with the right technique and with the right machine, N2 disease operated do require post-operative. And any margin positive patients do require post-operative. So that's how I think we can keep it as, that's what I come to that. Okay, a lot of post-operative in this. So N2 disease, stage 1 and 2 do not require any post-operative unless the margins are positive. So stage 1 and 2, only margins are positive, will give PORT. Stage 3, when there is an N2 disease, definitely we need to go for it. And the question of, do you consider PORT for all stage 3 N2? I think so. We should go for it.
So Dr. Vishweshwara, we would like to learn, because we are all medical oncologists and we have surgical oncologists. So what do you take care when you give post-op RT? Yes, you mentioned about cardiac toxicity. Yes, you will also try to cause less and less pneumonitis. So what are the precautions that you take while giving RT to such patients?
The main cooperation with the surgeons and things like that, while they're leaving the clips, when they do a good surgery, they should leave the clips there. That's very, very important. At what levels the nodes were positive. So there's a very close cooperation with the surgical oncologist we do work. So yeah, whether the disease was going to the posterior mediastinum, unnecessarily posterior mediastinum was treated, and esophagitis, and the problem in the aorta would start off like that. So we work closely with the surgical oncologist, plan with them, and with the proper surgical clips, with IMRT, and with a very focused radiation to that, take care of the mediastinum, take care of the primary, and that they are only the microscopic disease, R0 also, and the dose would be around 60 gray. 60 gray in 30 fractions would be nothing. That will be given for acceptable for any other body. But if the fields are larger, as you said, now it's pneumonitis, cardiotoxicity, esophagitis, all things start off. Already there is a patient with the loss of lung volumes, then they'll be in trouble. So these are the major precautions. We need to have a very good tumor board pre-op discussion and work very closely with our medical oncologist, surgical oncologist, and radiation oncologist. That is the key for success, I feel so.
I think you covered it all, and I think we really don't know about all these things, and thank you for educating us on this point. Mind my ignorance on this. Is there any role of protons in such a case? We just read it when we were reading for our exam long back.
This I'll tell you. I'm coming to that point. One point I forgot. Now with the advent of active breathing control and gating techniques, so we can really track the tumor, so and exactly give the things. And very few trials have told that protons have an edge over conventional radiation therapy, because the physical characteristics of the beam is it just falls off after the maximum effect. But proton has got an edge, but the very expensiveness of this equipment and availability has made a still lesser usage. But definitely in short period of 4 to 5 years, what you call the respiratory gating and respiratory 4D breathing techniques, everything has been started in many of the hospitals. When we use 4D breathing techniques, definitely the lung volume is minimal. Earlier, a lot of margins used to give, because to cover up the disease. Otherwise, we would have had a geographic miss, just like shooting somewhere else and trying to get into that. So that is totally taken away, and the side effects are very minimal with the respiratory gating techniques.
Rahul, can I have a question? Can I have a question?
Absolutely, sir. Even we love that.
Yeah, this is for Vishweshwara, Dr. Vishweshwara.
Namaskara.
Namaste, sir. Sir, one thing you mentioned about 66 gray in post-operative. Do you really give 66?
60, sir. Sorry, 60. 6,000 centigrade. Because they did a trial between 60 and 72.
Okay.
Not much difference. But 60 gray is a dose given in post-operative setting for all microscopic adenocarcinoma, whether it may be breast, whether it may be colon, wherever it is, the 60 gray in conventional fractions is the dose given for a microscopic disease.
Okay. The next question I want to ask is, what is the role of SBRT at present days?
At present? Adjuvant.
Adjuvant or definitive treatment? Whatever.
As an adjuvant or as a primary treatment, sir?
Primary treatment.
So that's what I told in the beginning itself. It is a learning curve. And once it becomes, you get a hold of it, definitely we can treat the very in specific indications less than 4 centimeters and peripheral tumors. Peripheral tumors, no negative patients. Not to come into the near to the hilum or near to the mediastinum. Only peripheral tumors are very well settled. Otherwise, a little bit misfire, the patient can die on 3rd day, because they are highly hypofractionated, 7 gray or 8 gray per fraction in 3 or 4 fractions to be given, and the risk is very high, as you know. And peripheral tumors are best suited for that. And size also, as you said, 4 centimeter, I will take it as a capping limit.
Thank you.
Right.
Thank you.
So we'll move forward, and I think this is what we've discussed: stage 1A, 1B, 2B, and
Dr.
3A.
Sood, sir, apologies to interrupt, but you have last 2 minutes to conclude.
Superb. So I now I can grill my medical oncologist. So that's all I need. So we've already discussed neoadjuvant chemotherapy, chemoradiation, the role of neoadjuvant therapy. When is neoadjuvant therapy indicated in early lung cancer? So question to Dr. Rohan, if he's joined back. Last,
yes,
what is neoadjuvant therapy indicated in early lung cancer?
So I generally don't think of neoadjuvant chemotherapy in early lung cancer.
Absolutely. And I think we should not as much as possible. I will agree with you. Neoadjuvant TKI and IO, Dr. Rudresh, your take?
Yeah, I am also not in favor of giving neoadjuvant.
Absolutely. So done and dusted. So again to Dr. Rohan and then Dr. Rudresh, you routinely test for EGFR in early stage 1 to stage 3B NSCLC. Yes and no, or no?
Till today, no, sir. So, but with the
tomorrow, from tomorrow, I mean Monday morning.
Definitely, sir. Whoever can afford osimertinib, yes, sir, definitely.
No, we are not going osimertinib at all. We're just going for EGFR right now. So not osimertinib. So EGFR coupons are available. So coupons are available. So yes, EGFR testing.
I would.
Right. Dr. Rajiv, Dr. Rudresh.
Rahul, yeah. As of now, there is no guidelines to do it. But as the Flora study started, we have started doing this EGFR in early stage also. I prefer to do it wherever feasible and possible because tissue is the issue.
Right.
So wherever it is possible, I want to do it. Maybe in the future we may get some data on that, so it may be helpful. So that is what my concern.
So I think it's a double-edged sword. We should do it and keep it with us. But then there are patients who will come and demand for drugs accordingly. But see, this is what is the guidelines. NCCN recommends it. The European, which is always against the Americans, do not recommend it, and the STM recommends it. So should we be testing a debate for this? But yes, with osimertinib being approved in adjuvant therapy in India of March 2021, I think more and more people are doing it. So we heard about the DFS, which was there in the ADURA trial, and a word from all three of us, our medical oncologists, one by one. Is ADURA trial a complete trial, or is it still an ADURA trial because the OS benefit has not yet come? So starting with Dr. Rohan first, is DFS good enough?
Yes, sir. In the context of lung cancer, I would say yes, sir.
Right. Dr. Rudresh, ADURA practice changing?
I don't think practice changing, but DFS is the initial step for OS.
Right. Dr. Rajiv, your take?
Yeah. As we believe the DFS may convert or translate into OS survival, as of now, there is no other data to justify. So we can accept as of now. So future, the complete data is out, then it will be useful for us to adopt for the practice. So that may be practice changing. As of now, it is again we are on the crossroads. We have to take a call depending upon the patient's acceptance. We have to explain the data and we can proceed. We cannot go unilaterally and decide. That is what I feel at the present state.
I think all three of you answered it in your own way, and that is what I also believe. We need more data, and the only way we can get more data is by putting more and more patients on osimertinib after doing EGFR upfront. And so if we have our own data, we can work better. So that was my last slide. I would end with this, and I would like to thank all our panelists, starting with Wing Commander Raj Mohan, Dr. Vishweshwara, Dr. Rohan, Dr. Rudresh, and Dr. Rajiv. Thank you very much for your participation.
Thank you, Rahul, for the very nice panel discussion. Thank you all other panelists.
Thank you so much. Thank you.
So thank you, Dr. Sood sir, for such a brilliant deliberation, and I think there's a lot of learning for everyone. And we move forward for the last part of the session. And this again is a talk. Dr. Rahul Sood is going to talk upon the usage of elastometric pump in chemotherapy segment. So good evening once again, Dr. Rahul Sood, sir. Over to you for your presentation, please.
Yeah, thank you once again. And in all our conferences, I love to keep some topics which we can practically use and we are using, so that we can educate not only the doctors who over a time period, including me, become ignorant to daily use of things which we rely very heavily on our nursing staff as well as our technical staff, and do give them an order of doing it without actually knowing what is being done. So we discussed about PICC lines in our last conference, and today I thank Baxter for giving me this opportunity to talk about pumps in oncology, which are probably the boon now, as more and more patients are being put on infusion pumps and taking chemotherapy at home, especially during the COVID times, and especially during the time when shopping at home and Swiggy is the way to go forward, and people do not want to go to places from here and there. So I start with this. So what are these devices? We've seen these infusion pumps very, very often, and we really don't know how they work, but it was a big learning for me. But these are the infusion pumps which are there, and they are the portable devices which can provide not only chemo, but outpatient antibiotics as well as analgesics, and can give long-term anti-iron therapy in the form of chelation. So these pumps are the ones which are attached to the IV lines, and the chemotherapy or the chelation agents or the analgesias are given either through the intravenous route, through the central or peripheral lines, subcutaneous lines. Epidurals are given in the form of analgesics or continuous peripheral nerve blocks, and surgical side catheter analgesias are also given through these routes. So the advantage with this is you can just carry it like a mobile phone and keep doing your work. We had people even from the IT company who continue to do their work while getting infusion chemotherapy, vis-a-vis those electronic pumps which are gone now into probably a oblivion, or I can say fossil, where the electronic ambulatory systems were being used up there. So how does this system work? So this Baxter has come up with this engineered form of infuser operations, which is a pump which is made of a plastic jacket, which consists of this elastic material, which is filled by the drug. Once it is filled up like a balloon, it starts to deflate slowly and gradually, and keeps delivering the drug. The distal lure lock is there, which is initially locked, and once you need to start the drug, this is what it is done. I'll follow it with a video as we go forward. So the infusers provide slow flow. This is the part of the infuser pump where the drug is infused through into the balloon or the elastic balloon, and there are various markings which are there. As you can see, at a particular time, 240 ml of the drug can be given, and it has various parts as it is shown in this picture. The rigid plastic housing is there, which is very, very durable, and how the drug progresses, that is how it empties, is by these various serrations which are there, which not only tells the patient but also the caregiver that how much of drug is left. Also, how do we give infusions at different rates? So with this, there is a rate adjustment tool which is there, and this can be adjusted to various setting depending on the rate at which the infusion is given. There are infusions which are given over 12 hours, 24 hours, 48 hours, and so on and so forth. So this is like a regulator. It's like a regulator of the fan which controls the speed of the fluid. And this is how it works. It has a valve where the no flow is there. Flow A is a particular type. Flow B is more than that, and flow A and B is even more than that. So these are the ways it works. So what is the benefit of it? The benefit is for all: the patient, yes, he doesn't require admission and he can keep doing his work while the infusion is going on. For the nurse, yes, the workload is decreased. She just puts it. She doesn't need to monitor it. The clinician is very, very happy. He can use those beds for other patients, and the patient can be mobile all the time. And for the hospital, where always the capital investment is there, especially in our hospital where the beds are always at a premium, the patient can be treated as an outpatient. So these are the benefits. Again, it allows ambulation for the patient. It is lightweight and noiseless and can be even used in humid environment, which is not there for other. The healthcare workers, yes, rapidly you can set it up, easy to affix patient labels, and quick identification can be done. Fast check for the end of the infusion can be made. It's very, very safe because it's engineered in such a way that there are various check mechanisms at every end. Data of interaction with drugs is also available. So in case you want to mix two drugs and give it, that is also available. Reliability, it has a good reliability because it has a good serviceability from the company which makes it, Baxter in this case. So what about advantage over ambulatory electronic pumps? Electricity is never reliable, and we know there are problems with electricity. So as compared to this non-electrical based pumps are very, very easy to use. There are better patient satisfaction. There was in fact a study which was done which showed that it checked the boxes anywhere. It was smaller in size, the weight was less, it was more patient friendly, and there was less impact on sleep, which is very, very important for an oncology patient. So what are the uses? Where is it used? In oncology, we give 5-fluorouracil, which is a common drug, but we also give protocols like VAD or VAMP in myeloma, where we can mix all the drugs and give it to the patient of multiple myeloma. So majority of times we tend to go towards capecitabine, which is not a very good drug, thinking that the patient can do with tablets. But I think with these infusion pump, the 5-FU can be infused properly. Infectious diseases like cystic fibrosis, acute infection, IV antibiotics over a long period of time can be given. Also, acute pain management, I think this is very, very important, not just for anesthesia, but also in oncology, because pain management is a different topic altogether. We need to give pain blocks, epidural. This is very, very important. So if we can give these infusions to our oncology patients, through these elastomas, it can relieve a lot of pain over a long period of time. We know we have morphine, we know we have those patches available, but the tolerance to those is very, very poor. So post-operative pain management is one more. And yes, chelation, which was there, desferoxamine, which was being given for iron overload. We don't see that much in oncology, but in general medicine, we see for refractory anemias or thalassemias. This is one more place where these pumps can be used. I'll stop sharing this slide right now, and I'll request Aru, if you could just show the demo, and I can tell them for the education of all how it goes. Right. So the infuser pump are made by Baxter, and this is the cabinet where we assemble the chemotherapy and infuse it into the pump. This is how the pump looks like. It comes in a very nice packaging, and the tubing is removed, and it is freed from the seed, which is done, and this is the chemotherapy which is being loaded into a syringe. At a time, we take a 50 ml syringe. It is important not to use a beveled syringe into the Baxter pump. The Baxter pump is lifted and it is turned upside down. The protective cap is removed and it is kept. It is not thrown away. The syringe is screwed into the end of this, and the filling goes anti-gravity. As you can see, the syringe is facing up, and the Baxter pump or the infuser pump is facing down. So it is against the gravity. That is how it needs to be done. And the elastic balloon fills up. Usually, because it is a 240 ml capacity, you may need to fill it at multiple times. Once it is filled up, the cap which we have is put back at that place, and the connector, which is the stopper which is there, is removed, and you can then check it. The chemotherapy the drug is now starting, and you can see drop by drop, drop by drop, it starts. You can put the rate regulator on it, and this is the protective cap which is there, and this is connected to the IV line and provides it. It can be connected to the central line as well as the peripheral line, to a three-way, to a needle, so so the patient can move with that. So that's all my presentation, and thank you for the patient listening, and I give it back to the organizers.
So thank you, sir, for this demo and for this presentation. Now we come to an end of this exciting 1.5 hour program on the management of lung cancer. So over to you, Dr. Rahul Sood, with your final words and concluding remarks, and then we say goodbye to everyone. Over to you, sir.
Right. So thank you one and all for joining as well as staying with us on this Saturday evening. I think lung cancer is an evolving field, and early lung cancer is something which is very much missed by us, and patient comes to us when the cancer is in the advanced stage. Osimertinib has come as a promising drug in the adjuvant setting. We have come to know of it through the ADAURA trial, and we need to put it in practice. In metastatic lung cancer, yes, there's no doubt about it that the osimertinib is the way to go forward for in the first line for metastatic EGFR lung cancer. We also know that the pumps that we use for giving chemotherapy are very, very important, and we've learned this in the last 2 years as the patients have dwindled and continued their chemotherapy during COVID time. So a very, very patient-friendly device for use. So I would like to thank our academic partners, AstraZeneca, who have always helped us for imparting medical knowledge. And thank you to Baxter again for giving us this opportunity to relearn what we had forgotten regarding the pumps. And to Tarun and his team, Horizon, as always, on time and very well conducted program for today. So Tarun, over to you. Thank you very much.
Thank you so much from all of us from the organizing team and the academic partners. Thank you. Stay safe, stay blessed. Have a great evening. Enjoy your Sunday, and all yours for a Monday morning. Good night to everyone, sir.
Thank you.